So we have with us tonight, joining us from Everett Bone and Joint, orthopedic surgeon Dr. Jeff Mason, and Bruce Overstreet with his segment, Overstreet Over 50. And we're going to start out tonight talking to both of you. Bruce, if you want to jump in here, we're going to talk about baseball injuries with Dr. Mason. It is that time of year. Tom and I were just talking. I mean, tomorrow night, opening night with the Mariners. I mean, how exciting.
Started, yeah.
Yeah. So we wanted to kind of talk about common baseball injuries. We hear a lot about a lot of these overuse and traumatic type injuries, but with baseball upon us, Dr. Mason, you being an orthopedic surgeon, and you probably see a lot of shoulders and elbows and different type of injuries. So tell us, what are the most common baseball injuries?
Well, absolutely, the upper extremity stuff is what we see the most. I think it's all rooted in the fact that even though you think of throwing as one of the things that humans are extremely good at, but it's a very stressful activity for the upper extremity. I tell people it's like playing crack the whip, except the end of your arm is the whip. And imagine halfway through cracking the whip, all of a sudden you're trying to decelerate and stop everything. So you use your whole body, your hips, your upper body to generate all of this force. And the moment you have let go of the ball, then you're trying to control, reduce, and eliminate all this force. So the forces on your upper extremity, the shoulder and the elbow, are very impressive.
Yeah, and you just described the mechanics of throwing, which is totally unnatural for the human being. And what you're describing is basically you're kind of creating this force going from your legs up through your trunk and then out through your arm, and the ultimate energy is in that ball that's getting whipped around there. And you talked about the deceleration. So when you're coming back and you're throwing, you have to stop that throwing motion. Isn't that where most of the injuries occur?
Yeah, we get the issue. People have pain at different parts of the motion, and so sometimes they will have pain with acceleration, the cocking phase, and all that. And that's usually what's called internal impingement, and it's a variety of the kind of subacromial pain or the shoulder pain we see in a lot of people. Except in throwing athletes, it's the cause is different. What you have with them is they get such good rotation of the shoulder that they can externally rotate a lot more than normal people can, but their internal rotation is reduced. It makes the back of the shoulder joint tight, so when they lift their arm up, what happens is the head of the arm, the humerus, gets shoved up in the joint more than it does in a person who doesn't have that phenomenon, and it hurts. And so they'll hurt right as they're getting ready to release the ball, and then as they release the ball, then all of a sudden you're putting all this force on the biceps and the labrum and all that. So there are a whole bunch of different ways it can all go wrong.
So the impingement you're talking about in the shoulder is basically you're compressing kind of soft tissue, or most likely tendons and bursa, that fluid-filled sac underneath that, what we call the acromion. That's what's happening. You're going to get compression, soft tissue between bones in.
Yeah, you get the humeral head goes up and pinches the rotator cuff and the bursa against the acromion. There's just too much force. Everyone has some contact there when they just lift their arm up overhead, but when it hurts, there's too much, it's too forceful, it's chronically irritating.
Hey, Doc, if I can toss in a little thought here. So I just started playing baseball as my spring activity.
Something else, Bruce?
I'm down with the Puget Sound Senior Baseball League. And so for the last week, I've been thrown against the wall. And I'll tell you what, I've taken more Advil in the last week than I've taken in the last 5 years. So my question is that a good thing?
Yeah, it's a good thing. What you really want to do is start out with some kind of throwing program. When we're rehabilitating throwers from injuries, they'll start out, and it'll drive them nuts, but we'll say, guess what, you're playing catch, and when you start out, the other guy is 15 or 20 feet away. And then you move up as your capabilities increase without symptoms. But if you're going to start to throw, you want to work on your motion without using any force. So throwing against a wall, that kind of thing is a good idea.
And I have definitely been doing the moderation program. I mean, certainly haven't been doing more than 10 minutes at a chunk out there against the wall. But,
start slow.
But it really has been sore. But we're getting stronger.
Well, the soreness that you're experiencing, though, Bruce, I mean, can you describe it? Is it a soreness from like a pinching type pain, or is it achiness? Does it keep you up at night? And those are all things that I think, Dr. Mason, if Bruce was to come to your office, you would want to take a history and get some input from him, and then you would kind of be able to differential diagnose what's going on, because he might just have tendonitis. What's the difference? How can you have just tendonitis and not impingement?
Well, what I'm hoping at this stage from his description is that what he's actually having is muscle soreness, because remember, we're talking about that deceleration. That's what's called an eccentric muscle contraction. Eccentric muscle contractions are what make your muscles hurt. As they say in backpacking, you get tired going uphill, you get sore going downhill. That's because that's an eccentric contraction. So if you're throwing a ball, that deceleration irritates the muscles, so any muscle soreness will be a lot greater than it might be if you started some other variety of exercise program.
Well, I think it is muscle soreness. My concern down the road, to be honest with you, I just don't want to wear out my arm over the course of the next 3-4 months. So
what you want to do is do a lot of stretching and work particularly to maintain your internal rotation.
And one of the things we found too is,
wait.
Go ahead.
Say again what internal rotation
is. The best way to put it is if you hold your arm up and rotate it out like you're going to reach up for your ear, that's external rotation. Internal rotation is when you're reaching back for your wallet. And so you want to make sure you don't get tight in internal rotation.
And you know what's interesting?
Shannon never reaches for his wallet.
That's right. That's right. I learned. That's why I'm tight in internal rotation.
Listen,
healthy. Though, if you ever get a chance to take and look at those phases of pitching, if you look at how they're broken down in the wind-up and the cocking, the release and stuff like that, look at the motion. I mean, the shoulder joint is doing some incredible movement that, it doesn't occur in everyday life.
Yeah, there was you could probably even find it on YouTube. There was a series of videos many years ago where they took professional pitchers and just put them in a pair of running shorts and their cleats and said, go up there in the mound and throw, and we're going to do slow-mo photography. And watching it is astonishing, and from a medical viewpoint, it almost makes you cringe because what they do to their bodies is just remarkable.
Well, right. Why haven't we figured this out?
Well,
Major League you're spending $8 zillion on your payroll. Why haven't we figured out some different way of doing it?
Well, there are a couple of reasons. One is that what they are being asked to do is at the limits of what the body can perform. I tell people all the time that the greatest freaks in athletics to me are not the guys you would think of, someone like Kobe Bryant who's 6'7" and can jump 40-some inches. That's astonishing. But the baseball pitchers who can do that to one joint of their body, throw the ball that way, and maintain it for a career, that's what's remarkable.
Right. It's pretty amazing. Tom, if you look at the anatomy of the shoulder, Dr. Mason was describing you have a big ball and a small socket, and what gives that joint the stability is this rotator cuff and these parascapular muscles. That's soft tissue. And when you start winding that soft tissue up and throwing, you're going to create impingement, you're going to create tendonitis, and we just talked to Bruce. He's got just a general soreness in his shoulder. But how would Bruce know at his age? Because you're not going to see these 12, 13, 14-year-old kids that are coming in like rotator cuff tears, right? Generally speaking.
Not tears, but you will see bursitis and inflammation.
Right, which is diagnosed by, you're just going to take them through some movement, and you're not generally going to do an X-ray and MRI. You're going to diagnose that just based on physical.
Exactly. An MRI would not change the way you treated it, so you wouldn't do that initially by any means.
Now, someone like Bruce's age, no offense here, Bruce, but over 50.
That's right.
He's got a little potential maybe to have a small tear in his cuff mechanism there.
Yeah, so that can be difficult because if he comes in and his shoulder is sore and we think he has a small cuff tear, what we're trying to do is distinguish him from all those other guys out there who have asymptomatic small rotator cuff tears, and we're trying to decide if this is what's causing him pain or if it's just bursitis, tendonitis, and how to manage it.
And tell us about that, because you just mentioned asymptomatic rotator cuff tears. So what you're saying is basically a large percent of the population out there that are certain over 50 are going to have potentially small tears in their cuff that just aren't problematic.
Yeah, approximately half of the males in the country over 50 have a partial thickness rotator cuff tear, and the vast majority of them have no symptoms. They don't know it, whether or not they're inactive or not doing this or that. But in many cases, these are people who are, very active, and it just doesn't hurt. I always tell people that I think rotator cuff tears hurt more because of what the tear is doing rather than whether the tear is there or not.
And that's a kind of a cardinal sign of a cuff tear is pain and night pain and just weakness. Tell us, if Bruce was to have a cuff problem or needed attention, what kind of symptoms does that tear present?
Well, it's usually sharp pain with certain positions or motions. It's often very irritating and awakens people at night multiple times. And it just doesn't feel like that muscular pain. There's typically little or no pain at rest unless the tear is quite large. And so you'll have people who say, gee, I feel like I'm fine, and then I reach a certain way or do something with my arm, and sometimes they say, gee, it goes from 0 to 100 in a moment, where I feel like someone stuck me with an ice pick, and 5 seconds ago I had no symptoms whatsoever.
Yeah, Bruce, now your shoulder symptoms that you're having are related to increased throwing activity.
Right.
Are you having night pain or
no,
problems?
I'm not. No, I'm not. But in anticipation of that happening, what does one do to really be ahead of the game? The preventative measures.
Well, you're doing what you should do.
But as far as would one of those bands, that you use?
Oh, absolutely. Anything you want to do to specifically strengthen the rotator cuff muscles is terrific. A lot of people don't like to do that because even if they're used to exercising, rotator cuff exercises tend to be time-consuming, especially for people who are really trying to improve their strength and endurance rather than just rehabilitate. And I tell people, yeah, you're going to use some tiny little weight, and then you're going to say, can I do 25, 35, 45 reps? Which, of course, gets you to the point where, it's tiring, it hurts in the exercise sense, it's time-consuming, but it pays big dividends.
Well, my big concern is getting out there, and a month into it, I'm sidelined. Like many of those guys in their 40s and 50s, the injured reserve list already before the season's even started is pretty long on our team.
Yes.
So.
Well, one of the things that we've learned in physical therapy and the rehab side of the shoulder, and this, Dr. Mason, is the shoulder blade, or what we call the scapula, or the upper back strength and function of that shoulder blade is really important because, again, the shoulder is very mechanical, and if that scapula is not moving right or stabilized on the chest wall, that force could be transferred into that cuff or that soft tissue. So upper back exercises are really important.
Well, absolutely. And one of the phenomenon that we see all the time that's closely related to this is people will come in and they'll say, gee, I had this pain, and they'll point to the outer edge of their shoulder and they have an obvious tendonitis or bursitis, and they said, and that was a couple months ago, and now I've got pain that's going up to my ear, and I've got pain going to the middle of my upper back. And what's happening is all these muscles involved with the shoulder blade and the neck are doing jobs that they're not supposed to do, as this person is involuntary and unconsciously trying to figure out ways to use their arm without hurting it. So next thing you know, the whole thing's spreading out and the whole upper extremity is irritated.
So can you watch someone on videotape, or can they come into your office and now watch me throw a pitch or whatever and go, okay, there it is. Your arm's too high. Can you change that? Of course, then I guess then your velocity goes away too.
Yeah, that's very much not within the scope of my training. So sometimes if it's really strange or obvious, I can. But more often, if I think that someone is at a level that's appropriate, I'll try to find an appropriate coach or someone to try to change their mechanics. And this actually touches on the remark you made earlier where you said, why haven't we figured this out? One of the things to keep in mind is, kids start out playing Little League, and they're throwing the ball, and let's just say that they have talent and they have, and they're willing to work hard and they're good at it. You have to go very, very far up into baseball to find people who are deeply talented and deeply interested in the biomechanics of throwing a ball. And so, if you get someone who's suddenly, a AAA guy and who looks like he's going to the majors, or maybe he's in the majors and he's very successful, if he starts developing problems, well, one, he's developing sometimes problems that stem from motions that he's been working on and perfecting for 15 or 20 years. And then you say, okay, you're supposed to do this with your elbow, this with your shoulder instead. And all of a sudden the guy's 97-mile-an-hour fastball is now 88 miles an hour, and he's losing control, and he's losing what got him there. And so these guys are more inclined to say, tell you what, why don't you just give me a Tommy John surgery and I'll come back and do it the same next year, and maybe it'll be okay. Sometimes it is and sometimes it's not.
Yeah, it's pretty amazing, just the feet, just the throwing and the repetition of throwing and stuff. And that's really important is as these kids progress is that they have good coaching and someone's watching how much they throw. Because with Bruce over here, he just started throwing. Most likely his symptoms are going to calm down as he kind of progresses and kind of gets his body into shape. But he shouldn't keep throwing if he keeps having pain. Someone's got to say, he'll say because he's an adult, but with kids, someone's got to be able to say no more.
Right. And, they have pitch counts in Little League, which have really had this fairly marked effect in how many of these kids we see appearing with shoulder issues and elbow issues. It used to be, 15 or 20 years ago, is much more common than it is now. And nowadays, the kid gets X number of pitches depending on his age, and they just pull him off the field. And people watch. I mean, occasionally you have coaches protesting that the kid literally had 2 pitches too many, and et cetera, et cetera. But the basic idea of limiting them and how much they can pitch it's a very good idea.
Now I understand they're also looking at eliminating or minimizing the curveball, or working on a cutter pitch as opposed to the extreme curveballs.
Yeah, and I've heard something about that, but I don't follow Little League closely enough to know exactly what they're doing about that.
They have specific pitch types based on age. And, but sometimes you have to be careful with age, because you can have a 12-year-old that looks like an 18-year-old, and you can have an 18-year-old that looks like a 12-year-old. So, the proper way to describe that and recommend that is, we say if you don't have facial hair, don't throw a curve, because your body's just not ready for it. That's kind of an easy template to use. But talk about the elbow. That's kind of where we're going with this Little League elbow, right, and the problems there. It starts at 11 or 12 with throwing too much, but an 11-year-old elbow bone and growth plates are different than a 20-year-old growth plate.
Oh, absolutely. And the area we see most commonly affected is the inside of the elbow, the medial part of the elbow, and that growth plate is typically not fused in those kids. And with the stress put on the elbow, we call it a valgus stress in medicine, but all it means is that the forearm, if you hold your palm in front of you, is being forced to the outside, and that growth plate, it's a traction injury, and it gets tugged on too much, and all of a sudden the cartilage connection between the place where bone is growing and the other place where bone is growing can start breaking down and getting irritated, and on rare occasions you actually have to go in and fix it. More often it responds to rest and therapy, but occasionally someone will come in and you say, well, wait a sec, that thing is way out of place and it's not going to heal, and you need to do something about it.
And when you're talking about a traction type injury, it's on the inside of the elbow. This Little League elbow, this phenomenon we call Little League elbow, is basically where a ligament is connecting the upper body or the upper body bone to the lower body bone, or upper arm bone to the lower arm bone, and it pulls on those attachment sites.
That's exactly right.
And the growth plate's not ossified or completely calcified,
exactly.
so
it's not strong enough to handle that.
And symptoms are early on symptoms. Any kind of elbow pain in any kind of Little League person is a caution.
Yeah, you pay attention immediately.
And does it go away with rest?
It can go away with rest, but a lot of times they sort of hover. They say, gee, I rested a little bit and it got mostly better, so I went out and played. Now it's back. I rested a little bit. So sometimes you just have to sit people, which nobody likes.
Best way to rule it out? Any problem? X-ray, CAT scan?
X-rays can show you something, but they don't always. But the physical examination is always pretty darn clear.
Tom, you've got some music going in the background.
We're going to take a break.
You're going to take a break.
Okay,
we'll be back.
But both these guys are going to stay with us, Bruce Overstreet and Jeff Mason. We'll come back with more Health Matters on a Monday on Fox Sports 1380.